Good afternoon and welcome to Getting Ready for the Maryland Primary Care Program update. This evening we're going to talk about comprehensiveness and coordination. I'm Dr. Howard Haft. I'm the Executive Director of the Program Management Office, and I will be the initial presenter. We'll walk through some of the key elements of comprehensiveness and coordination, and then I will turn the program over to my colleague Alice Sawinski-Rice, who will go over some more updates and issues related to preparing for the startup for the program. So let's get started. Going back to our requirements, the primary care functions, the 5 advanced primary care functions, over the last several weeks we've reviewed access and continuity in care management. And as you recall, just briefly, with access and continuity, we talked about the importance of empanelment and the importance of expanded access for our patients, whether it's through expanded office hours or continuous accessibility of practices, unique ways of setting up visits as group visits and home visits, or other ways to improve access. In care management, we talked about the importance of risk stratification and defining which patients specifically need short-term or long-term care management. And now we're moving along, building on those theories and those concepts and moving into comprehensiveness and coordination. I'll go over this very quickly, and again, this is designed to be just a very high-level view of those important concepts. As we get deeper into the program and after the launch of the program, which is now 74 days away, we'll have a lot more opportunity to go in detail about each one of these elements. So let's just talk about coordinated care. Coordinated care is about ensuring that there's a coordination of care, particularly around referral management for attributed beneficiaries, and particularly focusing on seeking care from those high-volume or high-cost specialists, EDs, and hospitals. This is a very simple concept, but one that's perhaps new to many practices, because most practices don't actually have a really good view of where their patients are going once they leave there, particularly fee-for-service beneficiaries who are free to go wherever they choose and may not need actual referrals. However, their activity is captured in claims, and these claims and the direction that patients go, and particularly the costs of those services that they seek, will be made available to practices. This is about a process that will allow you to identify where your patients go, to identify what the associated costs are for those patients, what the volumes of patients that are going to particular hospitals or emergency departments or specialists, and look at the relative value of each of those. And that we know that you as a primary care provider can certainly influence and help guide the direction that your patients go in, and will want to seek for them and for everyone the best value for your patients. So it's a matter of identifying those patterns, making contact when you identify an individual who is a high-volume provider for your patients, contacting that individual, and then developing coordinated care to make sure that you're getting back information that you need in a timely fashion from that specialist, that hospital, that emergency department, and coordinating it at a further level to make sure that when your patients seek care at that out of your facility location, that you are coordinating that care, that you can tell those individuals exactly what you want to have done for your patients, what you have already done, what you would like them to focus on, and what you don't need them to focus on, so there's no duplication of services. So in essence, this identifies those patterns, allows you to establish co-management or other kinds of agreements with those providers, and really smooths out and coordinates the care. The other piece of this coordination of care and comprehensiveness has to do with behavioral health. And we've all recognized for a long time that there has not been a great integration of behavioral health into primary care. It's something that we've known that would be important to do, but has been a challenge for most, if not all, primary care offices to be able to adequately integrate behavioral health. Within the Maryland Primary Care Program, we're really going to provide additional resources and additional technical assistance, allow that to happen in a more robust way. This is to ensure that beneficiaries who have behavioral health needs have access to care that's consistent with at least one of these options that we're going to talk about over the next several slides, to make sure that their behavioral health needs are adequately addressed. Let's go on to the next slide. So the sequence of events for doing that at a high level again is first to identify those patients who may benefit from behavioral health services. And it could be any one of a number of problems that patients present with. It could be patients who have serious mental illness who may be easily identified, but it could also be patients who have substance use disorders who, until you actually go to the effort of asking some specific questions, may not rise to the surface of your recognition. But it could also be patients with depression, anxiety, or other mental health conditions, or patients who have these behavioral health conditions and also have other social risk factors, or patients who have multiple medical comorbidities who have contributing behavioral health issues, as someone who has diabetes and is depressed and perhaps not taking their medication as they should, or other kinds of things that I think you already recognize. But within this system, we'll be able to not only identify those patients, but link them up to services either directly within the office or very tightly linked to your primary care offices. And that's usually done by doing some surveying of the patients on a regular basis and asking them simple series of questions that either you or your staff can ask on a regular interval. Next slide. So one way to address the delivery of these services is to do co-located behavioral health management. And in this way, there would be a behavioral health specialist in the office who is co-located. Actually, they're physically located there. And that could be a social worker, it could be a psychologist, it could be a psychiatrist. And in some circumstances, it could be tele-behavioral health. And in some of these circumstances, those individuals can continue to bill for the services they provide. In some circumstances, depending on the size and the need for the office, they could be there on a full-time basis, or they could be co-located on a part-time basis in the office. Very individualized depending on your population, your individual practice. And it could include any one of these behavioral health specialists. But there's other alternative ways to provide service also. Another way is, for instance, have a team member who's trained in managing behavioral health conditions. And that person would have an intimate link and communicate with those behavioral health specialists who might not be co-located. This is exemplified in the collaborative care model, where an individual in the office, a care manager perhaps, or others, does those screenings, identifies those patients, and does the initial evaluations and enters the information into the records, but then communicates with the external behavioral health specialist on a regular basis. This is also a billable service under the collaborative care model. But there are other ways of doing this. It could be that an individual in your office setting has been waivered under the medication-assisted treatment waiver, and you're doing on a regular basis the screening, brief intervention, and referral to treatment, and using that individual as the source for initial behavioral health treatment. And that individual can be linked to one of the statewide programs in a hub and spoke model. Or there could be other individuals in the office who have specific behavioral health training and can deal with individuals who have depression and anxiety and other kinds of behavioral health issues. So in short, there's several ways in which we can really improve the way we integrate behavioral health services into our primary care offices. But it's important to note that so many of our primary care patients have behavioral health issues that otherwise go unattended. And this leads to a lot of additional morbidity and potential mortality, and certainly a lot of additional emergency department and hospital visits that could be avoided otherwise. So that's at a high level just what we wanted to touch on today in terms of in terms of comprehensiveness and coordination. But let me now, again, remind you that there are financial supports in addition to the technical assistance for all the services that will be improved and enhanced in the primary care program. Care management fees, which can be used to meet the care transformation requirements, to hire additional management personnel, as we just talked about, and to do all the other things listed here. And this paid on a prospective basis quarterly and not subject to any repayment. But then there's also the performance-based incentive payments, which are paid annually in advance. It can be used in whatever way you see fit, but can certainly use to augment staff. And the Track 2 portion of the program, comprehensive primary care payments, which are prepayments and an enhancement of the basic E&M code payments. But all of those are intended to allow you to do more creative things in terms of meeting these other requirements. And then for those practices who've chosen care transformation organizations, they can also provide considerable assistance in providing perhaps the licensed social workers or others who are behavioral health specialists, either on-site or at a distance. But they can also provide all of the other services for care coordination services and support for transitions and data analytics and technical assistance on how to do the standardized screening and other assistance to meeting the care transformation requirements. And for those practices that have selected care transformation organizations, I know they're already gearing up to provide these services. And then before we go into the very important but mundane process pieces that need to be done as a lead up to the actual startup, that is those application processes, I just want to remind everybody that that there's a lot of things that we have to do here, but there's a reason why we're doing them, and the reason is really to strengthen primary care in Maryland and ultimately to provide the best quality health we can for all Marylanders, and to take a very purposeful shift in the way we do things from this ever-increasing demand on the volume, and a shift from a volume-based system to one that rewards for value-based care. And in so doing, to avoid unnecessary visits for our patients to emergency departments and hospital visits. And I believe in the end it will show the whole nation that Maryland has found a better way forward, than we can be a leader in how we deliver health care, and starting with our great primary care providers. And I always like to close my portion with this quote from JFK in a speech that he delivered at Rice University in 1962. And he said that we chose to go to the moon in this decade and do other things not because they are easy, but because they are hard, and because that goal will serve to organize and measure the best of our energies and skills, because that is a challenge, because that challenge is one that we're willing to accept, one that we're unwilling to postpone, and one which we intend to win. And I think in the very same way, this challenge that we have to provide better health care at a lower cost for all Marylanders is, to me, the very same kind of challenge. So with that note, I would like to turn it over to my colleague, Alice Sawinski-Rice, who will walk us through some of those details.
Great. Thank you, Dr. Haas. So I'm going to start off with a timeline slide that if you've been watching our webinars weekly so far, you've seen before. And we're just going to talk through the high-level timeline from now until the end of the year, just to give you kind of a frame of reference for where we are now and then what's coming up. And then we'll jump into some more of the details on these things. So right now we're in the middle of October, and over the last 2 weeks, you've probably seen a lot of different communications coming out from CMS, letting you know whether or not you've gotten an initial preliminary approval to participate in the program. The key takeaway from these communications is to let you know that the deadline to submit some of the forms that have been requested is tomorrow, October 19th. So we'll talk through those forms in just a minute, but looking forward on the timeline, once the practices have submitted all these forms back to CMS, CMS is then going to spend the next week or two compiling all that information, especially for practices that have chosen to partner with a CTO. After all that's compiled, the CTOs are then going to get their own letters, And those letters are going to contain a list of practices that they've been partnered with, the practice tracks, and the CTO payment option that each practice has selected. We're expecting those letters to come out at the very end of this month, so CTOs should be on the lookout for that. And then shortly thereafter, in early November, we're going to release what's known as the CTO practice arrangement. And that's the document that's going to specifically define the relationship between the practices and their CTOs. In terms of the CTO timeline, we've actually made a slight update here. So we're going to be releasing the participation agreements for both CTOs and for practices in early December. Those participation agreements are what you're going to sign between you and CMS to officially define your participation in the program. And everything's going to be preliminary until that's signed with CMS. Also, as part of that, in early December, you're going to get a second package of materials that'll be some final onboarding pieces that you'll need to complete before the end of the year. And everything in that December communication is going to be due on December 21st. So please mark that date on your calendars, because if you don't turn in your materials before that date, you're not going to be able to participate in the program starting January 1st. So now let's talk about some of the different notifications that are coming out from CMS. I want to reiterate that it's very, very important for everyone to add the CMS inbox to your safe senders list. All official communications from CMS are going to come from this address. And as I mentioned, there's a lot of paperwork that's coming out over the next couple months, and CMS isn't going to give you an extension if email ended up in your spam. So please make sure that you're keeping an eye out for things coming from this address. In terms of outgoing communications, over the past 2 weeks, you probably saw a couple of different kinds of emails coming out. When we talked about this on our webinar last week, CMS was finishing up sending these e-blasts, and they were about to send out paper letters to practices. So just to recap, there were a few technical difficulties and things went out in a couple of different batches. So you may have gotten one of these emails, or you may have gotten all three. But just so you know, the three bullets that we have here are the subject lines from the emails that went out. So if you want, you can search your inboxes for these to see what you received. But just kind of a high level, the first email that went out was called Preliminary Application Review Results. And this was just a general email letting you know that you were preliminarily approved and that there would be forms coming that you would need to fill out. There was a second set of emails that went out about CTO practice pairings. And these emails were very straightforward. They just let you know who your CTO partner was if you had chosen to partner with a CTO. And even if you didn't have a CTO, you might have gotten one of these emails just confirming that you didn't have a CTO partner. And then the third group of emails that went out was a preliminary track 1 or track 2 approval. And we understand that this set of emails might have caused the most confusion, especially for people who might have been managing applications from multiple different sites. And it wasn't always clear which of your sites the email was referencing. So in order to clear up that confusion, CMS sent out physical paper letters to each practice with a clear track and a clear CTO partner. So those letters have been sent out. They were put in the mail last Friday, the 12th. So you should have already gotten these letters in your mailbox throughout the first half of this week. These were sent out to the practice address that was listed on your application, so that's where you should look to receive that mail. And just want to point out that anything that was contained in those letters is the final decision. CMS isn't allowing any appeals at this point. But we also want to emphasize that anything coming out from CMS at this time is just a preliminary approval. So your participation is still contingent on a program integrity screening. There's going to be a final attribution to make sure that your practice has 125 Medicare fee-for-service beneficiaries, and you also need to make sure to turn in all your documents on time. So in terms of next steps, As I said, you should have already heard something from CMS about your preliminary approval, either by mail, email, or by paper mail. And if you didn't qualify, you should have heard from CMS about that as well. If for some reason you haven't heard yet, go ahead and send CMS an email just to confirm the status of your application. But even if you're waiting for some final clarification, go ahead and submit the forms listed here because they are due tomorrow. So there's 3 big things that need to be turned in before the end of this week. First is the 588 payment form. And compared to the other 2, that one involves a little bit more work, so we're going to come back to that one. But the second 2 forms are very quick and easy, so we'll talk through those quickly. First, if you're partnering with a CTO, you need to send back what's called Form A, the CTO payment option selection form. And about 3/4 of applicants have chosen to partner with a CTO, so most of you probably do need to submit Form A. But this is a very simple checkbox form. You just write your application ID number at the top, and then check a box for which payment option you're selecting. So option 1 is if your CTO is going to provide the lead care manager, you're going to split your care management fees with the CTO 50-50. And if you pick option 2, then you as the practice are going to provide the lead care manager and drive a lot of the care coordination, and you will keep 70% of the care management fees and share 30% the CTO. For track 2 practices, you're going to need to fill out what we're calling Form B, and that's the CPCP form, or Comprehensive Primary Care Payment. Only about 10% of our applicants were selected for track 2, so if you're in track 1, you don't need to worry about this form at all. But again, this is a simple checkbox form. You put your application ID number at the top, and then there's a simple checkbox to select which percentage of your payments you'd like to receive via capitation and what percentage you want to keep fee for service. Both of these forms, Form A and Form B, you can just email back to CMS at the address that we listed before. And then just a quick sneak peek at what's coming up in December. So there's going to be a second package of materials coming out. You don't need to worry about these just yet, but we just want to give you a quick heads up since this is going to be a very tight turnaround from the beginning of December to December 21st. So there's going to be 2 portals that you'll need to sign up for, the EPI portal and EIDM, and both of those are just going to help facilitate data sharing and getting you into the main MDPCP portal. There's also going to be a data worksheet that you will turn back in along with your participation agreement and the CTO arrangement. Again, all these are coming out in December, so you don't need to worry about them just yet, but just a quick heads up about what's coming out. Now let's go into the 588 form. Again, this is due back tomorrow, so any practice that wants to participate in January will need to fill them out, and this is regardless of your track or your CTO partner. Just want to preemptively answer the most common questions that we always get on this. Absolutely every single practice site needs to fill out their own 588 form. So even if you filled out a 588 for a different program, you still need to fill one out for MDPCP. And even if you share a tax ID number with other practice sites, you still have to fill out your own. I'm going to pull up a sample form in just a second, but just to kind of talk through the general steps for what you need to do here. You need to download the form, print out a physical paper copy, and fill that out. We've had a couple of people try to email a scanned copy, and that's not going to work. You need to print out the form and then physically mail it back to CMS. They won't take it via email. There's a little bit of blank space in the top right-hand corner of the form where we want you to put in a little bit of information that's specific to this program. We'd like you to list your profit status for your organization, whether you're for-profit or nonprofit. Also write MDPCP, so the people at CMS know to process this form specifically for this program. And then also your application ID number so that CMS can tie this back to your application and your other practice information. So that'll be a 4-digit number that you'll find on any emails or confirmation messages that you got when you submitted your application. You also need to attach a signed bank letter or a voided check, and then put all of that in an envelope and mail that out to CMS. Once you've put it in the mail, please send it out with some sort of mail that has an overnight tracking number, and then send an email to CMS letting them know that you have mailed this and give them your tracking number. This is especially important so close to the end of the deadline. Please make sure that you send them a confirmation email before the end of the day tomorrow. That way they know to keep an eye out for your form. In terms of where exactly to mail the form, the address is listed on our website and in the instructions that we've linked to here. So take a look at those and make sure you get everything in tomorrow. It's a very quick screenshot of what this form actually looks like. So at the top, under the reason for submission, you're going to want to check the new EFT enrollment box. And over here on the right-hand side, you can see where there's some blank space to list your profit status, MDPCP, and your application number. Then in part 2, where it asks for your legal business name, that's where we're asking you to put your practice name, because these forms are going to be submitted and processed at the practice level. Then go ahead and fill in your practice address, your tax ID number, etc. And then we've X'd out here a couple of fields that actually aren't required, so you can skip right over them. You don't need to put in a Medicare ID number or any of your provider NPIs. A lot of practices have more than 3 providers, so we don't want to confuse anyone by just listing a few of them, so you can just go ahead and leave those fields blank. That does, however, make it really important for you to include your application number at the top of the form so that CMS can match up this form with your application. Then in part 3 is where you fill in your banking information, so your checking account number and all of that. And then the rest of the form is very, very straightforward. It's just some contact information and a signature page. And that is all you need to do to get that complete. So not a very hard form, but very, very critical. And CMS is expecting everyone to have this turned in by the end of the day tomorrow. So please make sure you get these forms in and that you send them a confirmation email so they know to keep an eye out for your forms. That is all the administrative topics that we have for today.
Thank you, Alice. Very well done. And now we'll open it up for any questions that the audience might have.
So our first question is whether all the snail mail have been sent out. Some of our offices have received them, while others have not. So yes, all the letters have gone out. If you're still waiting for official confirmation, you can send an email to CMS asking them to clarify what track your practices are approved for and what their CTO partner is. But while you're waiting for that confirmation, go ahead and fill out these forms and turn them in just to make sure that you get everything in before the deadline. The question here, who will be responsible for walking the behavioral health specialists through the billing practices? Example of how to bill and panel patients under PCP versus their other patients.
So I think we will be providing some technical assistance on all of those matters as we roll out the program. So we look to the overall program for technical assistance.
Will coaches be deployed by region? If yes, then where can we find information on the regions?
Coaches will be deployed more or less by regions. Those regions haven't been defined yet, will be defined further after there's the final allocation of practices and care transformations are done sometime in December.
Will the Program Management Office or CMS provide the risk stratification tool later in 2019?
So all practices will have the HCC scores with their patients. Those are not specifically to be used as risk stratification. Practices can do risk stratification using their electronic health record information based on clinical information, and we anticipate in the second or perhaps third quarter of 19 that the state will provide an enterprise risk stratification tool through the CRISP dashboard.
A follow-up to that about the risk stratification tool, will MDPCP be providing or recommending a risk stratification tool, or can the practices determine the risk stratification tool they choose to use?
So the answer to that is that certainly the practices are free to use and encouraged to use risk stratification at the practice level and be able to take a look through their clinical records and others things at how they risk stratify their patients. But in addition, there will be a enterprise tool across the state that the program will provide for use on a voluntary basis.
Question here about behavioral health. What are the special circumstances that must be met to use telebehavioral health as indicated in the co-location of behavioral health services?
So, that's a great question, and telebehavioral health can be used by anyone. In order to bill for those services, they would need to be consistent with the Medicare rules and regulations regarding telehealth billing.
Will draft CTO practice arrangements and practice participation agreements be released for comment? If so, what is the time frame?
So the CTO practice arrangements will be available sometime in early December or November. And those are fairly straightforward documents and will not be released for comment. But I believe when they're reviewed, they'll see that there's no clear need for additional comments on those.
Question is, would we have received a letter and an email from CMS, or is it possible if we only received a letter or an email? And yes, it is possible that either would have received only one email or perhaps just a letter. But unless you received something that explicitly told you that you didn't qualify for the program, you can assume that you've passed the first round of vetting, and you can move forward to the next step and go ahead and fill out the 3 required forms. Can we get a confirmation we sent in all the needed forms by October 19th? So one piece to that is that's why CMS is requesting you to use mail that has a tracking number attached to it when you mail in your 588s. That way you have confirmation that it's been delivered and CMS has received it. And the other 2 forms are coming via email, so you probably won't get official confirmation that they've been received, but you will on your end have some tracking that everything has been submitted. We have one practice commenting here that the emails about the CTO practice pairing in early October differ from the snail mail letter that they received this week, which is the source of truth. So the snail mail letter is the more accurate source of communication if this information does differ. But if you still want to verify with CMS, go ahead and send them an email. It's the address that we have up on the screen now, marylandmodel@cms.hhs.gov, and they will be able to confirm for you which one is accurate. I have a question here. Are we now able to register or log in to the EIDM and FE portals before December? And the answer is no. CMS is going to send out all that information in early December, so we're just bringing it up now so that everyone's aware and they know to keep an eye out for this information in probably the first week of December, but you don't need to worry about that right now. To elaborate on the data provided to identify high users of specialists. Will that be claims data?
Yes, that'll be claims data taken from the Medicare files.
Will care management fees be changing due to the volume of applications?
Care management fees only change depending on the HCC scores of the individual beneficiaries and the track in which the practice is in.
Behavioral health providers need to share patient notes with the primary care provider.
It's recommended that they share information, yes, and to the greatest extent possible. It's really a continuity of care, and to that point, sharing information between providers related to behavioral health information is permitted. It's not a HIPAA excluded activity.
Please provide a quick description of the lead care manager roles and duties as related to the CTO option form. Remind us where we can see a more detailed explanation of each role.
So in general, I'll read general rather than specific, the lead care manager is an individual who has taken over the primary responsibility of leading the care management program for an individual site. They may have others who work underneath them, but they would be designated as the one who runs that particular program. More details regarding that can be found in the request for applications.
Recommend having a risk adjustment trained coder available to help with risk stratification.
That's not really part of the program. In terms of risk stratification, it sounds like that's more related to how you would code in order to get different levels of HCC scores, and we're really not focused on that.
Question is, payments are calculated based on previous year's volume. What happens if a practice expands significantly within 1 year, such as adding 2 or more providers?
So the payments for care management fees would change depending on the attributed beneficiaries, not on the number of providers. So as the practice expands, additional adds of new beneficiaries as they become attributed to those practices would add to additional payments.
What was the primary reason practices applying for Track 2 were reassigned to Track 1? We are PCMH Level 3 certified and have questions.
So there are a variety of reasons why practices did not qualify for Track 2. It was done by a standard algorithm, which was held rigid across the board so that the logic was consistent. And there were a variety of different triggers for not passing, but essentially it was practices that were already providing essentially Track 2 services, not just PCMH Level 3, but the full compendium of Track 2 services and care, the high level of care coordination and connectivity to other practices, and were then brought into Track 2. I want to point out that it is the anticipation, the expectation that all practices will move as quickly as possible to Track 2. So in the second program year, we anticipate that many of the practices will move to Track 2, and certainly by the end of the third year, all must move to Track 2. So there is a rapid trajectory, and we'll do everything we can do to assist practices along that trajectory. So that if there's a small gap that can be easily overcome, it'll happen quickly. If there's larger gaps, it may take a little longer.
Thank you. Next question is, will HCC score updates be provided to practices? If yes, how often?
The final financial methodology has not been released yet. My understanding from the near final is that the HCC scores will be updated on an annual basis.
Are the attributed beneficiaries recalculated during the year? And this is in reference to offices that may expand their panel during the year.
Yeah, so the answer to that is it's on a quarterly basis. There's adds and deletes to the beneficiaries based on the attribution model. There were a number of questions related to care transformation organizations that we will be able to address next week. We'll have a separate care transformation organization meeting, and I would ask you to bring those questions up at that time. And while we're waiting to see if there are any other questions, I want to remind everyone, first, thank you for your patience. Thank you for your enthusiasm for the program. Let you know that we understand that there's a lot of administrative details that need to be attended to, but remind you also that once we finish with this, the administrative details, that they will be in the rearview mirror, and we'll be able to proceed with the much more exciting and applicable program of advancing primary care. So bear with us as we get through this administrative period.
I have an email from a CTO asking about the CTO meeting next week. So that will be on Wednesday, the 24th. If you don't mind, go ahead and send us an email to actually our state inbox, which is mdh.pcmodel@maryland.gov, and we'll make sure that if you're a CTO, you have all the details of that meeting. Had another question come in. How can we appeal our Track 1 determination?
So I want to state again that there are no appeals. All decisions are final. Okay. So not seeing any other questions, I thank you all for your time this evening. I look forward to chatting with you again this time next week. Have a great evening.